I'm very pleased to be here. It's always a pleasure to come over to the beauty of these places, and I'm very happy with the title I've been assigned. Even more, noticing that small airways now are going and developing, expanding outside obstructive lung disease. The next presentation will be on interstitial, so it means that the concept is there and it has some value. But I'll start with the old story: asthma and COPD, obstructive lung diseases. These are my potential conflict of interest, and briefly, thank you. What I'll go through in the next 20 minutes or so, it's the importance of small areas in the pathophysiology and in relation to clinical outcome in asthma. And then I will do the same in COPD. What's the relevance and what they are in COPD, integrating with what the evidence that they are relevant for the evolution, the severity, and eventually the treatment of the disease. So let's start with asthma. Asthma is an inflammatory disorder of the airways throughout the bronchial tree from central to peripheral airways, and this is clearly an example of involvement of peripheral airways. On the right hand side you can see a specimen of a patient, an asthmatic patient, a mild asthmatic patient who died for reasons different from asthma. Despite the mildness of the disease, he died for a car accident, and the control of the disease at the time when he died, you can see that the airways, the peripheral airways, more than 2 millimeters, are profoundly rearranged as compared to, on the left-hand side, a normal subject, matched for other clinical conditions. There is an increased thickening of the bronchial wall of the airway smooth muscle lower. You can see a mucus plug inside. A profound infiltration of inflammatory cells, the eosinophils, throughout the bronchiolar wall from the submucosa to the adventitia. So there is severe and massive involvement of small airways, even when we have a mild condition in asthma. What strikes me usually is the size of this compartment that we call small airways. Well, it's not that small. If we consider and compare it to what is termed the large airways, this small blue dot, the internal surface of small airways is much, much larger, hundreds of times larger than the internal size of the surface of large airways. So that's why the treatment, in particular, if we consider inflammation, should be much more directed to small airways because the size is much, much larger. Physiologically, what's the role? It has been tested with invasive techniques in asthma. This is a bronchoscopic technique, wedging the bronchoscope down where it can reach. So that's the size of peripheral and small airways. And even in mild asthma, as you can see on the right hand side, there is an increased resistance compared to normal subjects. There are several ways now of measuring the peripheral districts with non-invasive technique. This is one of the latest, probably the latest one. It is impulse oscillometry, which shows clearly that the different degree of severity, particularly in severe asthma with ultrasound, we can see an alteration in peripheral airways in terms of dysfunction of their activity. Probably the most standardized and the one that is more precisely, we'll see in a moment, assessing small airways, though difficult to do, is the nitrogen washout technique, which tell us mostly of the heterogeneity of the gas distribution in peripheral airways. And here we can see a relation with the clinical outcome. The greater on the y-axis is the impairment of small airways. The lower on the y-axis is the level of control, correlating impairment of small airways with clinical outcome. The same is true when we consider exacerbation, the other important clinical outcome that we consider in our management of the disease, those with more frequent exacerbation, more than 2, have on average a higher impairment of small airways, again assessed by nitrogen washout technique as compared to less frequent exacerbators. Even inflammation in peripheral airways, we'll see here measured on the left-hand side by nitrogen NO measurement, alveolar NO. We see that in patients with uncontrolled asthma, the average level is higher not only, but on the right-hand side, we can see a correlation, though weak, but is there, between the level of alveolar NO and the level of control. The higher the level of NO, the lower the level of control, again related to inflammation in peripheral airways. Even imaging. This is air trapping in the expiratory maneuver, and we can see that it is more frequent in severe asthmatic patients. The first pair of columns in black, particularly in acute severe condition and in very severe requiring ICU and mechanical ventilation, indicating that in the pathophysiology of the disease, particularly in the severe and in the acute condition as expected, the small airways are very much involved. Now, one of the problems is that we don't have a gold standard to assess small airways. We have seen some of the methods that have been used to differently assess different aspects actually of small airways, either resistance or compliance or elasticity or heterogeneity of the distribution. But all of them assess a different aspect. So in asthma, with the Atlantis study some time ago, it was done an assessment of all possible techniques, some of which we have mentioned now, and see what happened, whether we measure all with different technique the alteration of small airways, different aspects of the alteration of small airways, and eventually if we can organize some score to get a more objective and unique value of alteration of small airways. Now, the first important data in red is that 90% of asthmatic patients, whatever the severity, have at least one of the measurement of small airways, which is altered, which is indicating deficient small airways functioning or some type of alteration. Some of the measurements are more specific, particularly if we look at those related to nitrogen washout, Sachin and SCOND. Some are less sensitive. Look at the functional one, FEF 2575. We know that is not the most specific one to identify small airways disease. What has been done in this study, this is the cross-sectional phase of the study, has been putting together all the different measurements of small airways impairment to find out with the clinical SAT score that is organized in a way that takes into account all the different aspects of the alteration of small airways assessed by those different techniques. We can distinguish separate two different groups in terms of degree of impairment in small areas. And we can clearly see that group 1, look at the first row, has a greater impairment of small airways as compared to, a lower impairment of small airways compared to group 2, which is the one which the greatest impairment of this score related to small airway, and it is associated with some specific demographic characteristics, BMI, for example, severity of the disease as assessed by the GINA scale of treatment, severity of the hyperreactivity, that are all higher in patient with a greater severity of impairment in small airways. But it is on the major clinical outcome that the difference becomes huge. Here we can see that exacerbation, whatever the way we measure exacerbation, are associated with a greater degree of impairment in small airways in group 2 compared to group 1, whatever the definition, it is significant. And the same is true for asthma control. Different tools used to assess asthma control, but again, whatever the tool, it is always greater the impairment in small airways in patients with awards asthma control. So we found a correlation specifically putting together the outcome, the measurement associated to small airways with an increased risk of exacerbation and a lower level of asthma control. This is cross-sectional, and this is longitudinal. I took a couple of examples. One with impulse oscillometry on the upper panel. On the lower panel, it is a parameter related to lung function. And on the x-axis, as a continuum, we have a greater impairment of small airways. On the y-axis, the risk of exacerbation. And we can see that this, whatever the measure we use to assess the impairment of small airways, inevitably, the higher the impairment of small airways longitudinally, the greater the risk of exacerbations. Then what it has been done is to put together some of these parameters, the ordinal score, the three parameters related to impulse oscillometry, AX, X5, and R20 minus R5, and to see what happens in blue if we add this index to the assessment in terms of risk of exacerbation to a number of outcomes. You can see there lung function, severity of the disease in terms of treatment. By its own, the ordinal score, the last item, is associated with an increased risk of exacerbation, confirming that alteration in peripheral airways are associated with an increased risk of exacerbation. But what is more interesting is the penultimate one, where you can see that in red, without considering small airways, FEV1 is associated with an increased risk of exacerbation. Actually, the lower the FEV1, the greater the risk of exacerbation. However, if we look at the model 2, the same FEV1 in blue, when we add the ordinal score related to small airways, FEV1 is not anymore significantly indicating a risk of exacerbation, which means that when small airways are included, they overcome the importance of large airways in predicting the risk of exacerbation. A correlation with the same index has been found also with different tools assessing asthma control, ACT and ACQ6, reinforcing in a statistical precise way the concept of the importance of the peripheral districts in terms of clinical outcome. More specifically, this is a group, the same group of patients, those of the Atlantic study, different degree of asthma severity, that have been assessed by the presence or absence of fixed airflow limitation, i.e. FEV1 and VC below 0.7 after bronchodilators. And what was found is not, this is not novel per se, is that those with fixed airflow limitation in blue have an increased risk of exacerbation compared to those without fixed airflow limitation. Looking at the determinants of fixed airflow limitation, it has been found that several of these determinants, in fact, are related to small airways, contributing, strangely enough, to the fixed airflow limitation that we usually associate with large airways, but in fact is mainly associated with small airways and the consequent risk of exacerbations. That's why it's so important to reach and treat that peripheral district. And for this, it comes to our help this seminal study by Omar Usmani some time ago, showing on the right-hand side that the lower the size of the particle for treating the airways, the greater the deposition that we can get down to 1.5 micron to get a good deposition. So we have a way to reach this peripheral district the way we want, to have a deposition on the components of the airways where we have seen all these alterations are located. And indeed, using this formulation, we can get changes in the pathophysiology of one of the most characteristic, for example, finding in asthma, which is eosinophilic infiltration in the airways, both central and peripheral airways. And you can see here, with formulation that reach peripheral airways, we can decrease the inflammation even in peripheral airways. We can modify the patencies of the airways. Bronchodilation, if we want to say, this is a treatment with an ICS LABA with the formulation that reach peripheral airways. And what is here is a three-dimensional CT scan, which takes into account, actually, it's an algorithm that takes into account the size of the particle, the geometry of the airways of the single patient, the inspiratory flow, and the changes after treatment are indicated in this scale. The hotter is the color, the greater are the changes in terms of patency of the airways. And we can see that the most important changes, the hottest one, are clearly in the peripheral district. Even one of the most resistant finding in asthma, which is remodeling, in this case, it is assessed by airway smooth muscle layer density, which is increased both in central and peripheral airways, is significantly decreased, probably more in peripheral than in central airways, after treating with a formulation that can reach that peripheral district. It's not surprising, therefore, that in terms of clinical output, we have evidence of advantages when we can reach the peripheral district, one way or the other. In this case, for example, it is just an inhaled corticosteroids and an extra fine formulation in violet compared to a non-extra fine formulation that cannot reach the peripheral airways. Please note that the dose of the extra fine is half of the dose of the non-extra fine. So with half the dose on the y-axis, we have the change in asthma control in terms of improvement. With half the dose of extra fine formulation over time, we can see a greater improvement in asthma control compared to double dose of ICS with not extra fine. And this is an ICS lab, and it is related to asthma control, percentage of symptom-free days. Again, with half the dose of inhaled corticosteroid in red, we can reach a greater level of percentage of symptoms-free day. All these data, the efficacy ones, come from very controlled trial. We need a very controlled trial to tell us what happened in a very standardized condition, not to have variable that can confound what is the outcome and the answer that we look for. But we know that real life is very different. Many variables are there. Many confounding factors are there. So it's important to have the confirmation of what we have found in randomized trial, controlled trial in real life. And this is one example. It is what happened in terms of risk of asthma control in this case, using a formulation that can reach peripheral airways compared to formulation of the same inhaled corticosteroid without the formulation that reach peripheral airways. And you can see the advantage in terms of control of getting the peripheral disc, and the same is true in terms of prediction of exacerbations. So not only in control condition and in theoretical condition, but in practical clinical practice, having formulation that can reach peripheral areas do provide an advantage. Briefly on COPD, it should be even more straightforward in COPD, and it is actually, given that, well, by definition, COPD it starts and it is located in peripheral airways. It is in the pathophysiology. Small airways are named as such. In particular, the inflammation in small airways is related to the pathology and to the severity, actually, of the disease, even in terms of airflow limitation. It is an historical study, by Jim Hogg, that found a correlation between the severity of the airflow limitation as assessed by the gold stage and the severity of the infiltration in peripheral airways of all the inflammatory cells we know are involved in COPD, regulatory, effector cells. So the correlation even goes beyond the airflow limitation to the to the emphysema degree. This comes from the group of Marina Saetta, where she, long time ago, found the correlation between the severity of the degree of score, emphysema score in pathological samples compared to the intensity of the inflammation, again in peripheral airways. Is it relevant from a physiological standpoint? Well, in normal condition, to say the truth, peripheral airways do contribute not much to the overall resistance. They account around 10% of the overall resistance of the respiratory tract. The situation is different when we have an obstruction, as for the disease that we are discussing now. Since changes in internal diameter are inversely related to the power of 4 to the overall resistance. So small changes in the internal diameter in this condition do change a lot the overall resistance, and indeed in obstructive lung disease it is the peripheral district, the site where most of the resistance is located. It is frequent, very frequent. This has been done with impulse oscillometry. You can see according to A, B, C, D category, then we can discuss whether this is the proper way to do it, but according to the A, B, C, D category, particularly in those with frequent exacerbation and high symptoms, gold D, but also high symptoms even without exacerbation. But I would say also the mildest one, gold A. 50% of patients in gold A at the very beginning of the story, they have an impairment in small airways, even before COPD. These three groups, in red there is a COPD group. In pale green there is a group with no airflow limitation and no alteration in small airways. In dark green you see a group of patients with no airflow limitation and impairment in small airways as assessed by MMEF. And it is correlated to the impairment in PROs, in this case, the MMRC score. So already in patients that are the very initial story of smoking without having fixed airflow limitation, they have a worse MMRC score. And this patient, please look at the last line of the table, are those at higher risk of developing COPD because in patient with impairment of small airway and not yet fixed airflow limitation, the decline in FEV1 per year is twice as much those of those that have no COPD and no impairment in small airways. This group of patients with just impairment of small airways and no airflow limitation, 1/5 of this patient will develop COPD within 10 years. It is related to peripheral district with important clinical outcome. This is SGRQ, assessed with impulse oscillometry, the impairment of small airways on the y-axis. The greater the impairment, the lower the level of quality of life. Exacerbation, in this case, assessed as risk factor by imaging. Alteration related to small airways are associated with 50% increase risk of exacerbation and mortality, which is not an irrelevant outcome. Again, a study from Jim Hogg in patient underlying lung volume reduction what it was found was that the greater the impairment in small airways, in terms of occlusion of small airways, the lower was the life expectancy of this patient, associating the alteration in small airways with survival. One question is, there is a process down in peripheral airways, particularly in COPD, and the issue is it worth going there with treatment? Are these alterations sensitive to the treatment we want to drive into peripheral airways? And the answer is yes. This is corticosteroid efficacy on inflammation in peripheral airways. What you can see here is a nice dose response curve of 17 beclometasone monopropionate against LPS-induced interleukin-8 on the A-axis on cells that have been obtained by BAL, so they are really peripheral airway cells, and you can see a nice decrease of the production of inflammation by increasing the corticosteroids, so there is sensitivity irrespective of the population from which these cells are derived, including COPD patients. So also in COPD, we have a sensitivity in cell derived from peripheral airways to inhaled corticosteroids. How about bronchodilator? Nice. These are video macroscopic bronchioles, precision slides, a single slide, seeing the movement of the airways after adding the bronchodilator in bronchoconstricted airways. The nice dose response of formoterol when we can reach peripheral airways. This is what happened in a bronchoconstrict slice after the addition of peripheral airways, in peripheral airways of a bronchodilator. Yes, we have a response. And when we put them together, we have the advantages of having all the molecules in the single site, improving pharmacologically the interaction between them, which provides an effect in terms of patency of the airways, which is greater than the one we expect by the sum. The single color are the three components of a triple therapy, ICS, TABA-LAMA. The gray, dark gray is what we have when we put that together, and the light gray is what we would expect just by adding the single effects, and we can see that the real effect, the dark gray, is higher than the addition of the single effect in small airways, indicating that there is a pharmacological interaction, synergistically potentiating each one effect. Finally, the advantage is that by targeting peripheral airways, we get exactly where we need to go, which means that we can reduce the overall dose of the drug, because a greater proportion of the drugs goes directly on the place where it should go. So there is no dispersion around in other places. So if it is true that pneumonia is a side effect common in COPD, particularly with inhaled corticosteroid, and the left-hand side we can see that the higher the dose of inhaled corticosteroid, the greater the risk of pneumonia. This doesn't happen when we use a formulation that can reach the peripheral airways, given the fact that we are staying on the low part of the curve with low doses and reducing the risk of these side effects. Not only lower airways, but also upper airways, because with this formulation, the impact of the inhaled corticosteroid, for example, this is just one example, on the upper airways is reduced, the deposition is reduced, and the side effects related to it is lower. So we have really an advantage in terms of pathophysiology and related outcome, and a reduced risk of side effects. In asthma, they are there. Impairment of peripheral airways is there even in mild asthma. Different methods have been assessed, finding out different techniques that can tell us different aspects of peripheral airways. In any case, finding out that the addition of to an algorithm of peripheral airways makes them known as even more relevant than central airways in predicting clinical outcome. We can reach peripheral airways with formulation that gets down to the peripheral district, changing the pathology of the disease with clinical benefit, both in randomized controlled trial and in real life. In COPD, we have even more strict association between the impairment of small airways and the alteration of the disease. They are frequent in all type of gold classification. They are related to important clinical outcome. They are associated to alteration even before having fixed airflow limitation, with potential benefit associated with the lower exposure, for example, to innate corticosteroids. Side effects associated to corticosteroids, such as deposition in the upper airway and pneumonia related to deposition in the lower airways. And with this, I would like to thank you for your attention.